Hi everyone. My pleasure to be here last day, and obviously, there's not much between this session and your flight back today. What I'm going to do in the next 15 minutes or so, I'll talk about a little bit how EMR structured and what to expect. We're all excited to get data in electronic medical record, and sometimes when we start, it is a very naive view to see that's probably a magic button what we click and get all this data ready for analysis or a research project. Obviously, it's not. And a lot of that actually burned in a history. If you look back to the time, there are not much happened until recent years in electronic matters or so. But really, back to 16th, 17th century, that was bill of mortality. That kind of record how document cause of the death or so. Then later, that progressed to something what we can call lab journal, and that was before modern EMR. What it actually was, the patient went to physician, and physician had a little note in own journal which explained what's going on with patient. When patient go to another physician or so, another physician had lab journal, his or her own lab journal, and this lab journal had exactly the same kind of impression on the patient. That's obviously that was no interoperability or so. What happened at the beginning of the 20th century, Dr. Henry Plummer at Mayo Clinic created something what called patient medical number, and that's a kind of start modern medical record. He actually assigned for every patient number, and this number was a type of the dossier of the documents which actually coming with the patient. When patient arrive at Mayo, which become multidisciplinary group practice, literally patient take this dossier and go from one physician to another, and they add information, impression to this dossier. That was attached to the patient, and that kind of become proobraz of the modern medical record. Obviously, there was something in the 40s, Swedish medical record looks like pretty much what we had on the paper before electronic medical record, and Dr. Larry Witt introduced this concept of patient-oriented medical record. There are excellent lectures on the YouTube about that. In 70s, we got bedside computers, especially in a critical care, and they monitors or so, but they are grossly disconnected from everything. And in 2000, we got electronic medical records, most famous, and these days, Epic, Cerner or so, but they are coming back to 2000. But when we look to data in this medical record, we start to appreciate complexity of that. It's not single database. It's a multiple database, and traditionally medical record was a billing administrative system which was done for a purpose of the proper documentation to get paid. Then on the top of that was a documentation system which mostly originates from an outpatient clinic and how you document patient visit or so on. But when we came to complex inpatient care, we see a lot supplementary systems exist. And pathology, they have own system, radiology, they have PACS system. If we talk about charting system, that's a completely separate database could be different vendor or so. There are many different systems exist, and the number of them could be up to 100 in a modern hospital. Still, even if you have Epic as a main electronic medical record. Obviously, they need to communicate each other in some way. And really we come to something what we called clinical terminology and clinical healthcare data standards. There are a big difference between two of them. For clinical data standards, which SNAMED, very well known standard, ICD-10, LONIX or CPT codes, the role of them is determine what information to send and how to standardize this information. But healthcare data standards, HL7, FHIR interfaces, DICOM for imaging, and SNAMED CT also fall in this category as well. They answer the question how to transfer the data. They are more about transferring data properly rather than make the standard. And surprisingly, healthcare has a lot of coding systems in existence. I mean, they are all in a work, they all exist and use these days. But again, as you can notice here, I will not go through all of them, but you can notice here there are different coding systems exist for a different type of information. Like, for example, RX norm is for drugs and drug delivery, and nothing else could be coded in this system. There are some codes which exist for very specific purpose, like there is for psychiatry and mental health, there are separate type of the coding system. Obviously, when we want to pull data in single place from the patient, we need to deal with all this complexity. Obviously, when we extract meaningful data, we want to filter out irrelevant information. The modern electronic medical record system like Epic, they contained more than 10,000 tables. And as we understand, 10,000 tables do not contain any, all this table not contain clinically relevant information. You need to filter out irrelevant information. And obviously there are challenges in data cleaning, which always present errors, human errors and all of that. And on the top of this, we need to standardize data elements for interoperability, because all this, even inside hospital clinical system, they need to talk to each other and smoothly exchange information. On the other side, it's compliance and security in data management. We have HIPAA and we need to follow patient privacy as well. Yeah, secure data usage for research, because this is still patient data, and later we can de-identify patient data for more broad usage, but that's another layer of the complexity. I give you example of Mayo Clinic ICU data mart, what we created back to 2006, dealing with exact complexity what I described. At that time, we had fully digitized electronic medical record, one of the first in the United States. It was not Epic by any means, but to be able to extract data pertinent to critical care patient, we pull data out of the very different electronic sources, databases, and so on. I mean, that was like complex work, but as a result, the system database was near real time and 15 minutes delay to real time, which was capable to run any algorithms, test any algorithms, and even use it for a practice purpose or so. Okay, yeah, that's what. Yeah, we describe this complexity, but how we will live in the future? Yeah, maybe there are AI, machine learning, and all these like modern terms. They solve these problems. For some degree, yes. Yeah, that's obviously these tools would be helpful, and the role of them will increase in data standardization, mapping, and all this kind of the stuff. Would it be nice if you ask database with natural language, say, I want the data for septic patients from January to 2025 in this specific unit, and please export me this in Excel format. I mean, that's very close to that, but we are not there yet. Blockchain, like a couple years ago, everybody talked about blockchain. These days, we don't hear anything much of that, except coins. But it's a pretty good instrument for security and interoperability. But because it takes a lot of resources to generate these blockchains, it's probably not practical to use. But we should not exclude that would be one of the instruments to secure information. Cloud computing in EHR systems, obviously everything these days in a cloud. But from user perspective, for us, it doesn't matter. It's a data sitting in a closet in a basement of a hospital, or data sitting in somewhere in a like Amazon data center somewhere. It's the same databases, but kind of centralized and putting in some like environment. Personal medical records. That's something what probably how we will see electronic medical records in like 10, 20 years, maybe later, because return of investments for modern EMRs, like 13, 20 years. But the point is data, every patient, we are all patients, and every patient has data attached to yourself. This is like Dr. Plummer did back 100 years. The data attached to the person, and when you admit to the hospital or go to provider, you just grant access to your data. They do all this part, what they need to do, billing and so, and push data back to your personal storage. And you go to another place, and data available in another place. It just was not advertised, and this is Apple Health screenshot from Apple Health, but you can go there and type name of the hospital, and surprisingly, you found what you can connect to your medical record in particular hospital. There are many, many hospitals there. I have no counts, but yeah, there are a lot of them. All right, that's conclusions and takeaways. Standardization is essential. We need standards, and yeah, that's no question about it. Filtering ensure relevance, because there are a lot noise, a lot data, and for busy clinicians or researchers, you need clean data. HIPAA compliance must be integrated in all these systems and all data transfer. And obviously, we are looking to future AI, blockchain, cloud computing, and personal health records. That's my last slide. Thank you.
Just to be respectful, if anybody needs to ask questions now, we will have a panel with opportunity for questions later, but I know some of you are in a hurry. Please come forward, otherwise we'll move on to our next talk. Okay. Thank you so much, Vitaly. Our next speaker is Dr. Eric Rosenthal. He is the associate professor at Harvard Medical School. He's also the director of the Neuro AI Center and participant in the Neuro Recovery and Neurotechnology program. So welcoming Dr. Eric Rosenthal.
Thank you, Pooja. Okay, great. So I'm going to talk a little bit today about the sort of step-by-step process of how One might extract data from clinical data sources, and I don't think there is a single one-size-fits-all. That'll be a general message, but I'll show you one approach as well as multiple different data types. These are disclosures of funding, and the two at the top are the ones I'm going to talk about today. So the work that I'm going to talk about is taking part through a consortium of several hospitals focused on collecting a set of data at the bottom. And you can see electronic health record data is not the only type of data that is of interest. So I'm going to talk about some of the other data types: imaging, telemetry, waveforms, social determinants, and then one piece of data I think is quite relevant, which is data about ourselves. So we're very interested in data about patients, but we forgot to ask a little bit about ourselves. We, together with the patient, make the outcome. And so if we are just modeling the patient and not what we're doing to the patient or how we act, that's important to know. For example, what's the average dose of anesthetics used at your hospital versus mine? So busy slide, but this gives you just sort of an example in our data set, and there's a lot of ways to do this, but this has to be done in any relational databases, how the data is linked. So for example, here, if you can see my arrow. It's pointed to something that says a root directory. So this could be the sepsis registry, or it could be a hospital specifically, or it could be a merged data set for the SCCM. And then here are patients. And what you'll notice here is before you get to the specific patients, at least in our registry, we're listing all data that's labeled OMOP, which is it's an observational medical outcome partnership, which has sort of object data of electronic health record data stored in a very highly formatted way. And you may have heard of other tools like FHIR, which is an interoperability standard, but one of the reasons that the work that we're doing is using OMOP is that it's very highly described in terms of the metadata, where it came from, the concepts, and that it, for research, is a little more reliable to build phenotypes. It may not be necessarily what you want to deploy an algorithm on, but it's very, very rich and helpful for developing, answering research questions and making or quality questions, and so forth. The reason why this is outside of the tree where each patient is because you would have a group of patient data all there. So you would have in that table, we'll talk about it later, a medication folder or table. You would have a table on observations such as heart failure. You'd have a table on measurements, such as the blood pressure and so forth, nursing assessments and so forth. And then we, for each patient, then organize different objects, so an image, radiology or pathology, and waveforms, brain waves or telemetry, separately from that. And one of the reasons is that it becomes harder once you separate OMOP data into each patient to actually pool it and use a lot of the tools that exist. When you do this and you're making a relational data set, there has to be linkages, and these are shown by some of the colored lines here, that a patient is the same patient as the same patient. And obviously we wouldn't want to list that patient's name, so we have to give that patient an identifier. And a hospital, if they don't want to share that information for privacy, then has to have what's called a mapping table to know that when they look up an individual, that individual is 0001. These types of data are represented in standards, and part of the reason for that is this free market that we live in which data is often written in different standards. You may have Philips or GE or Neocoden monitors for your waveform data at the bottom, but we've chosen the standard that has been operationalized by Mimic, and we're sort of modifying it slightly for our own purposes, but we find that is a standard. There are other standards like I listed HDF5, and these are usually hierarchical standards in which you'd have waveform data for a file for a specific episode of care, and then you might have a folder, just like in your computer, the blood pressure and then the heart, ECG and so forth. And when you label that at your center, it may not be the same label as mine. So for EKG, there's relatively standardized labels like, lead 1, lead 2, V1, and so forth. And there are standards, like even through DICOM, in which you can port those channels. But at my center, we might label it differently than you. So one would actually have to relabel that data so we're all talking the same language. With DICOM, we don't really have that issue for imaging because DICOM is a pretty broad standard, although there are some other standards. We have other issues there about de-identifying data we'll talk about. And then I mentioned the use of the tool stack through Odyssey, this observational health data sciences and informatics consortium, which is really a participatory consortium in which people are constantly innovating and have developed tools like using a OMA model, common data model with FHIR and so forth. But it's a very nice open consortium. But these represent that sort of Rosetta Stone. In terms of taking data through the steps, you have to be able to get it. And at different hospitals, there are different ways this happens. At my hospital, I have access for EHR data to a SQL repository. It's on a specific cloud. And I can interact directly. At another hospital, you might have to request this access. And it may have to go through a broker and a middle person. And that is sort of one main challenge if you want to get to a level of automation, because if there's a person in the middle, you're sort of waiting for them to do something. Standardizing the data to a format means that you need to harmonize the data so that when mine says, blood pressure right arm and yours says blood pressure brachial right, that we're talking about the same blood pressure, and we can sort of agree on that those names are the same thing. We'll talk about that. Third, I talked about linkages. And then fourth, we'll talk soon about de-identification. And then on the right, if you're when you're collaborating with others, you have to be able to check and say, we agree that these are the same thing. I'm going to talk a little bit about standardizing also waveform data. So Brian Gao at MIT and Beth Israel, who's a MIMIC investigator, worked with us in our project to look at different types of waveform standards that are out there. And you can see they're all represented here in different columns. And this is a larger table. I'm just showing at the bottom a small sample of HDF5 and the critical care data exchange format, WFDB, the waveform database format, XML, DICOM, Atrium. There's many different waveform standards. And one of the things we did was spend a lot of time looking through these evaluation. Do they handle breaks in the data if someone goes off to a CT scan and then comes back? Do they handle if one channel is a sparse sampling and the other is highly sampled? And what if there's different units? Not all formats do all those same things. And so we gave these sort of green, yellow, and red tokens here to give you a sense of what different formats do well and what they don't. And you can see up here, there's a lot of yellow and red, that not every format does everything perfectly. And if you look top to bottom, there's nothing that does everything. And in doing so, we did settle on the WFDB format because it does a lot of what we felt were important. And another part of that is being open and modifiable. But another dimension of that is that if you choose a standard, you want it to be a standard that's fast. So there are some standards that may be good, but when you look at them, and here each color is a different data set. So the 2018 PhysioNet Challenge data set, Charis, Emory-GE data set, MIMIC 3, 4. Each of these is represented here by a color, and then we're reading the data looking at 5-second blocks, 500 blocks in all the different channels, so blood pressure, heart rate, some of these have EEG and so forth. And we're trying to see what the speed is to actually read that data. And you can see, this is in seconds here, this one here is 450 seconds to read that data, and this one here is 50 seconds, so it's a 9x difference. And you may choose that format because you say, oh, it's DICOM, and I can then use it with my imaging, but now this is what you're dealing with. You're dealing with long compute and so forth. And the same is true for storage. Turning back to electronic health record data, when you map data from your center to mine, this is sort of in the bottom in green what it might look like. So we go through a process, and Smitty's going to talk about the standards that the Discovery has settled on through an extensive Delphi process. But let's pretend we're talking about mechanical ventilation, and a subtype of that sort of section is an endotracheal tube. and things about that. And a subtype of that is specifically what the cuff pressure is on the tube. And this is what it looks like at my center. It's called RPHS, IP, trach, and ETT cuff pressure. I don't know what it is at your center. And so someone went through this. In this case, it was me, and I said I'm a neurointensivist. And I linked this to a LOINC code called tube cuff pressure intubation tube. We worked with a medical ontologist, Polina Talapova, who's based in the Ukraine and has been able to still continue working with us through our collaboration with Tufts. And she would help us, as an ontologist, call this a broad match because it's not specific enough. It could be a trach or it could be an endotracheal tube, right? So that is a process one has to go so we're all talking the same language. And then we validate these and find, how many are exact, broad, narrow, related, and, and so forth. And I won't go through all that in detail. We had the chance for the Curing Coma campaign, which is through Neurocritical Care Society and external to that, to go through about 8 or 9 of their CDEs, which are common data elements. These would be, on a clipboard or red cap, things you check off. And what we did is we tried to look for all the data elements in there, and could we translate those to OMOP, whether they're from EHR or whether they have to be checked off by a human. And on the right is sort of the path to do that. And what you can find is that you can find links to some of these in different standards, SNOMED, LOINC, ICD-10, and so forth. And some of these are broad and narrow and other matches, and some of our measurements and so on and so forth. But in 8 CDs for one organization, you can see you could find almost 1,700 of these. So we did that work. If you wanted to then use that at your center, you would still have to take your electronic health record representation of that and match it to this CDE, this common data element. That's sort of the final mile, and it might look like a table like that. And then the last thing I'll just touch on is imaging. So if you want to collect imaging data, imaging in DICOM has pictures, JPEGs, in a file folder. But above that, there is what's called a header, which describes the file. This is the patient, this is who it is, this is what kind of image it is. And some of those tags tell you really important things, like this is an MRI and this is the sequence acquisition parameters. And some of them tell you private tags, like this is the patient's MRN and name and the date. There are systems like that. The Clinical Trial Protocol, CTP, through Radiologic Society North America, RSNA, is well oiled and can be used with certain recipes to sort of keep the private tags and extract the things that you wouldn't want to share. The harder part is when pixels get burned into the JPEG itself. Those are not sort of overlaid. You can't toggle them on and off. They're sort of part of the pixels. And there are a set of tools out there, some of which are academically developed and some of which are open source. Microsoft, Amazon has a few, and some of which are commercial. And what I would say the major lesson here is they work really well, but really well is not perfect. And so there usually has to be a human layer at the end, and the trick is, how does one de-identify at scale? Do you sort of collapse images so you can look at sequences at a time, or what's the trick to make it fast? Oh, and then I mentioned at the beginning about data about ourselves. You can also, and this is an open source pipeline we have a QR code to, you can extract the location at which the patient was from, not so that you can share their home address with anyone, but that's so you can link that, for example, to their, the economics of the local area, social vulnerability indices, social determinants of health, and so forth. And this is sort of an example of doing so. So in our data set, this is just, I pulled up my site, MGH, and measurements. This is what it might look like in a tool called the ARIES Data Quality Dashboard. You can see, you might want to look at the right eye pupil diameters, and you can see there's a lot of records per person. Not every patient has that measured for maybe obvious reasons. You could also look at drugs. It's a little smaller, but I looked up tranexamic acid, and you can see how many different formulations this is given in. And sometimes you want to harmonize, but sometimes there's still value in the detail. We're not talking about the same thing anymore because there are different formulations and so forth. So one has to consider that and so forth. So isn't just a recognition of some of the people who've contributed to this work, some of our open source data and access to it on the cloud. Thank you so much.
Thank you, Dr. Rosenthal. We'll keep questions for the end, I guess. That's what the group wants. The next talk is the Discovery Data Science Campaign with Dr. Heavner, who I know since the virus registry days. And he is the Senior Scientific Director at the Critical Path Institute, which is a public partner relationship with the FDA. And he is a new inductee from the Fellow of American College of Critical Care as of yesterday. So congratulations and welcome.
Right. My session yesterday was cursed by technical difficulties, so let's see if I escaped it for today. It's always a privilege and an honor to get to present with two colleagues that I've learned a lot from, and those that I've learned a lot alongside with across the years. It's a lot of trauma bonding back in those early days. My only disclosure is that though we are a public partnership with the FDA, nothing about this presentation should be construed as an endorsement from the FDA. There have been a couple of presentations about the data science campaign. If you missed any of the others, I encourage you to go back and listen to them on Congress Digital. There's a lot of other content beyond what I'm going to be able to share today. But big picture, the idea behind the data science campaign is to help modernize SCCM's approach to data sharing, harmonization, utilization, and our partnership with larger, more data science intense programs like Chorus, Bridge to AI, or N3C that exist outside of the society. As I do want to start with a little bit of acknowledgement. There are 3 papers that have been published over the last year out of this work. You can see there's a huge list of co-authors. So definitely want to call out the 4 authors that have served as chairs of these programs and committees: Karen Reuter-Rice, Jay Perrin-Cobb, Donna Armanack, and Jill Clermont. Donna, who was also inducted as a fellow yesterday, so if you happen to see her, be sure to congratulate her. I also want to call out Dave Murphy, who helped lead some of the Delphi's, Wes Anderson, who made tremendous contributions to building the C2D2. And if y'all will indulge me, I want to embarrass Tamara Al-Hakim, the SCCM staffer who has really dealt with this. Yeah, let's give her a little round of applause. She's done a lot for this work. So there's a lot, and the guiding principles document in particular is one of those that has a monster appendix attached to it. Encourage you to read those, but today I'm going to focus on the critical data for critical care, our primer on data science for clinicians. The data science campaign, specifically domain 1, under which this work rests, focused on 3 objectives. One was to establish principles for the society for how we think about data sharing and data harmonization across our partners, across our scientists, and across our health systems that participate in the society. We wanted to build and standardize a set of common data elements critical to the core of all research studies. And objective 3, which is still ongoing, is to demonstrate some pilot projects leveraging both those guiding principles and the use of the common data elements we develop. A little bit of an org chart, which somehow got shrunk since I built it. Built this slide deck, so that's always a fun thing to find as you're presenting, showing you where we rest under SCCM, Discovery, and the other committees that are represented there on that table. When you download the slides, you should be able to see a little bit more clearly. And just as a level setting, the intent behind this work is not to create a new data model, not to create a new data standard, not to undo the other work that's out there, and essentially and foundationally, the mindset, the mentality, and the approach of the data science campaign is based on the FAIR principles. That data should be findable, that people who want to access the data should be able to find it. There should be a process for how they access it, including processes that protect the privacy of the patients. That the data is reusable. The idea of one-off registries that can't be used for other research isn't a good use of our efforts and isn't being a good steward of the patient's data. And then finally, the data should be interoperable. And that's not that the data can be used in any context and perfectly fit to any study that will ever be chosen, but that we understand what it means in the context in which it was collected. And as we started this work, we conducted an evaluation, did a series of listening sessions, some focus group work, and some member checking activities that are all described in the primer paper. And we developed 6 organizing topics that helped us think about how we went about collecting our guiding principles, think about how we structured the critical care data dictionary, and think about how we would move forward as a society as Data Science Campaign 1.0, this kind of starting level of work. And those included data domains and common data elements, the concept of interoperability, which I've just talked about, data quality, which is that nebulous idea of clean data, but understanding what the data means in its context again, digital infrastructure and data harmonization, data access, sharing, and governance, and of course, all of that undergirded by ethics and equity. There are definitions listed, and this is table 1 from that paper, and they're discussed in more detail, but I'm going to anchor on 2 of them for this conversation today. Of course, these are not mutually exclusive. There's a lot of overlap, so they shouldn't be considered like thematic codes that can be applied to an interview, but rather the set of concepts and theories that need to be considered interdependently as you build any data science project. As we think about what a common data element is, what it means to have interoperable data, we looked to some of the use cases that have come up in the society and in our work. And this figure was developed as we thought about a specific use case. There was a publication in JAMA out of the virus registry by Dennison et al. Looking at metabolic syndrome in COVID patients. Fantastic publication, really well crafted, really well done. But as Pooja remembers, as we worked on that paper, we realized we didn't have the right common data element. In order to explore metabolic syndrome, we need to know their triglyceride level. But in order to interpret a triglyceride level, you have to know whether that patient had propofol, because of course that's going to raise their level, their triglyceride level. In virus, we had a daily value for did they have a triglyceride level, what was it? We had a daily indicator that the patient had propofol, but we didn't always know the temporal relationship. If the patient's triglyceride was on hospital day 1, propofol didn't start till hospital day 3, we're in the clear. But if they started on the same day, we didn't know whether that triglyceride actually represented a true triglyceride level or a level falsely elevated by medications we were giving them. So in order to actually conduct the study, we had to go back and collect additional data that would let us parse the relationship between those 2 data elements. And so here you can see a conceptual model of what that common data element should have looked like from the beginning to ensure that that data was interoperable and could be used for that specific study. There are some deep technical terms. Here we use the term identifier, which is what's used in data science to think about what is the actual thing that we're looking at and measuring. There's the units. There is the element itself, which will include concepts like the date and timestamp, helps get that temporality. And in this context, we might define the metadata as the relationship to that propofol infusion itself. So a plain language description of this might be triglyceride as measured in milligrams per deciliter collected prior to the first administration of propofol. That would give us a much clearer definition of what data actually needs to be collected and allow future use of that data to properly interpret the information. Now, that sounds like simple, but how do you actually anticipate all of the future potential use cases? We can also look at even simpler examples. If you want the highest blood pressure for your patient, what does that mean? If you have 2 values that have the same systolic, but their diastolics are different, what's the actual highest, or vice versa? Do you index on the map? If you want PF ratios, but all you're asking for is the highest PaO2 and the highest FiO2 in the day, you don't know the temporal relationship, you don't know if they're within 6 hours of each other, you can't actually calculate that information. And so what you end up with, if you want to do a cross-sectional CRF, which can be less time intensive, can be a good fit for a lot of studies, you end up having to anticipate a lot of the future uses of the data, a lot of the ways you want to analyze it, and a lot of the other factors around each data point that might help you understand the data you actually have. And that's when we might find that the actual EHR data itself is more useful. As Vitaly and as Eric have described, however, that data is incredibly complicated. Not only is there a big difference between Cerner data and Epic data, there is a big, big difference between Epic at hospital A and Epic at hospital B. Sometimes there's even a difference between the med-surg ICU and the neuro ICU and what the Epic instance actually looks like, or the Cerner instance. And that's where we start talking about common data models. If we put in the upfront effort, we get the data mapped to something like OMOP, which I currently see as the best option for EHR because of what Eric mentioned, the structured mapping of metadata, but also it's specifically designed for that use case. You can retain all of that granularity. You can retain the temporal relationships between those variables and understand the context of the care. You have the potential to map in something about the user itself if you have the right data sources. However, it's very time intensive to get there. That's where you might integrate with something like FHIR, the messaging standard that Vitaly mentioned. However, even though this is required by federal law, the implementation is tied to meaningful use criteria. So a lot of the data that we care about as critical care researchers aren't necessarily captured by FHIR resources. And so the point of this figure, the point of this section of the paper about interoperability, data harmonization, is that there isn't a one-size-fits-all approach, and you may end up needing to integrate multiple standards, and certainly you need to think about multiple vocabularies, as Vitaly put it out. Vitaly is probably going to roll his eyes at me about loving OMOP. He has this great cartoon about we don't need new standards, we need to work with what we've got. And so the table that he had up a little while ago is an excellent resource as you're talking to your data team, your informaticists, to get at the actual data you want. As we worked our way into building the guiding principles, as we continued building the data dictionary, we thought carefully about how the 6 guiding topics, the 6 organizing topics fit together and how they look across the life cycle of data. Going from generation through curation, conception to generation, all the way through reuse and destruction of the data, because at some point we have to plan for its destruction because of privacy, but also just because of storage costs. As we continue to iterate on this, as we work through this together as a society, we'll need to evolve on these models, evolve on these concepts. And so we look forward to people reading these papers, providing comment back, joining discussion groups to help us think about how we can make this a better process. But there's a lot. We started out with 500 candidate principles and ended up with 24. That's a lot of guiding principles for us to think about. But FAIR is still number 1. That's the foundation of it all. Through these discussions, through previous discussions, through your engagement with the society, you're going to hear about a lot of projects. The 3 at the top are they're the ones I mentioned because they're the ones I'm involved in, so I know a little bit more about them. There's Bridge to AI and Chorus as part of it. There's N3C. There's no shortage of projects and efforts out there to try to leverage the EHR, try to make that data more available, make it more interoperable. But what you'll find as you look into them, it's not that they're duplicating efforts, it's that they're each trying to solve a different challenge. And there is a need for the different approaches. There's a need to look at both federated and centralized approaches to harmonization and analysis. There are needs for these much more sophisticated models to handle waveform data, to handle imaging data, something that a lot of health systems aren't quite ready to deal with. But you'll find that because there's not one size fits all, there's a lot of things going on. And the goal then of the society through the data science campaign is to try to minimize the duplication and help make sure that we are benefiting as many people as possible through this work.